Steroids start, so mechanism of action. First of all, we know steroids are anti-inflammatory, right? And immunosuppressive drugs. And they do those things differently, different ways. The first thing steroids do, so look at the anti-inflammatory, also, of course, there's an overlap. Steroids can inhibit, right, the arachidonic acid pathway. Steroids can inhibit arachidonic acid pathway, so they can inhibit the COX enzyme, as well as inhibit what phospholipase A2, which is the enzyme, right, in the arachidonic acid pathway, right? So by inhibiting those enzymes, what happens to prostaglandin levels? Prostaglandins decreased, right? And prostaglandins decrease, and leukotriene, right, levels go down. Yeah. If their level go down, then patient, that will suppress our immune system, because we know prostaglandins and leukotrienes mediate, right, inflammation. Yeah. So by suppressing the arachidonic acid pathway, that is how they cause anti-inflammatory, right, effect. So that's one. Two, steroids, they inhibit the synthesis of what? Of inflammatory cytokines. That's another thing they do. They can suppress the formation of or activation of the genes, right, for inflammatory cytokines. So all those interleukin 1, TNF alpha, interleukin 6, interleukin 2, right, that activate both lymphocytes, that can activate phagocytes and bring inflammatory cells. They can suppress the genes, right, that make those interleukins and cytokines. Yeah, that's another thing they do. And they do that by preventing the activation of a transcription factor called what? NFKB. Yeah, there's a transcription factor called NFKB, and that factor is a transcription factor that lymphocytes use to turn on the genes, right, for cytokines, like interleukin 2 and co. So steroids, they can prevent the activation of that transcription factor and prevent the sense of those cytokines and suppress, right, the immune system, suppress inflammation, right? So that's second mechanism, NFK inhibition or degradation. Thirdly, steroids can trigger, right, the apoptosis of what? Lymphocyte. They can actually kill, like trigger cell death. Right, programmed cell death of lymphocytes, cause apoptosis of lymphocytes. They can also cause apoptosis of what? Of eosinophils, right, or trapping of eosinophils in lymph nodes. And then they can prevent the what? Prevent the exit. They can prevent neutrophils from leaving this blood and infiltrating the tissues. So remember, whenever there's like an infection in a tissue or there's a damage to a tissue, neutrophils need to leave the blood. Neutrophils will be in the blood, right? They have to leave the blood and infiltrate, right, the site of infection and cause inflammation, right? So steroids can prevent neutrophils from doing that. They can prevent neutrophils from doing that. Yeah. So they trap, you can say they trap neutrophils within the circulating blood, prevent them from leaving the blood and homing and exiting the blood vessels and getting to the site of inflammation. They can trigger cell death of lymphocytes and eosinophils. And this explains why in patients with steroid toxicity or somebody with Cushinism, if you check their CBC, what will you see? You're going to see neutrophilia. There'll be high neutrophils in the blood, since neutrophils can't leave. But you're going to see what? Lymphopenia. Lymphocytes will be low, eosinophils will be low, eosinopenia in the blood. But neutrophils will be high.
Okay.
You got that?
Yes.
So steroids kill lymphocytes, kill eosinophils, prevent neutrophils from leaving the blood vessels. So if I check my CBC, what will I see? Neutrophilia, high neutrophils in the circulating blood, low lymphocytes, low eosinophils. And that contributes to also what their anti-inflammatory and immunosuppressive, right, effect.
Yes, sir.
Okay. Side effect wise, okay, so we know how they work, which explains what we use them for. Inflammatory conditions, prevent transplant rejection, right? etc. Okay, so that's that. Another thing is side effect wise. So let's start from head to toe. Yeah, I like because steroid has so many side effects, right? So we go from head to toe so I don't miss anything. Before we go for head to toe, let's start with vitals, right? Vitals and then head to toe, and then we go to labs, and then we'll talk about imaging, right? So I don't miss anything. Vitals first, hypertension. Right, steroids can cause hypertension. And the side effect of steroid I'm going to talk about now, I'm talking about systemic steroid, right? Not just localized. This is systemic steroid. I'm taking oral, right? Or IV or IM steroids. The systemic steroid, these same side effects will apply to what? Cushinism, where patient has hypercortisolism. Somebody with a tumor that's making too much cortisol, same side effects, same presentation is what you're going to see, right? If somebody is taking steroids, right? Oral steroids or taking a high-end steroid or high-V steroid. So applies, right? Same thing. Okay. So in steroids, so from head to toe, from vitals, hypertension. Yeah, hypertension. Question is, how does steroids cause hypertension? One mechanism, mechanism is this. The mechanism is steroids they cause what we call, it increases the sensitivity of what catecholamine receptors to catecholamine. It increases the sensitivity of adrenergic receptors to catecholamines. So it makes alpha receptors and beta receptors more sensitive to norepinephrine and epinephrine. That's one of the ways it causes hypertension. So, and it's going to, if I increase the sensitivity of alpha-1 receptor to norepinephrine, what happens to TPR? Increased vasoconstriction, right? Yeah, and that will lead to what? High blood pressure. Higher blood pressure. If I increase the sensitivity of beta receptors to catecholamines, there will be increased cardiac output, and that will also contribute, right, to pressure, high blood pressure.
Yes, sir.
Okay. And then, if a patient is taking steroids, another thing is going to be what steroids also what is a mineralocorticoid. It has mineralocorticoid activity. So it's going to increase what? Sodium and water reabsorption. Awesome. So it's going to increase sodium and water reabsorption. And that also contributes to what? High blood pressure. Okay, so that's that. Then, those are your vitals. Now we go to physical exam head to toe. Starting from the head, patients that are taking steroids, right? If they're taking high dose steroids, they can have what? Psychosis. Yes. We'll call it steroid rage, right? Somebody start taking high dose steroids, they can develop psychosis, psychotic features, depression, hallucination, delusion, anxiety, a mixture, right, of neurologic, right, neuropsychiatric side effects, manifestations, right? Okay, so that's gonna be that. Highs, steroids can cause what? Glaucoma. If someone is taking topical steroids for maybe topical steroid as well as even systemic steroid, can cause what? Glaucoma. Actually, topical steroid, yeah. So glaucoma. Then we go down to, of course, we already talked about nasal steroid use, oral candidiasis, right? Or thrush. Yeah, it can cause dysphonia, atrophy of the muscles, right? in the oral cavity, in the pharynx, in the larynx, which can cause dysphonia. Yeah, dysphagia. Yeah, steroid spray. So that's that. Also, patients that are taking steroid spray, especially nasal steroid spray, they can be at risk for epistaxis, nosebleed, because remember, steroid is a thinning of the mucosa, thinning of the wall of the collagen, right? It impairs collagen synthesis. So the wall of the vessels in the nose can be thinned, and they can bleed easily. Yeah. So epistaxis from steroid, you can see that nasal steroid use can cause epistaxis. Okay. So we go down. There's no significant cardiac effect from steroids, maybe secondary effect of hypertension, the lungs, not really. Yeah, anti-inflammatory, so mostly beneficial. Give me a moment.
Yes, sir.
All right, yeah, so lungs, mostly beneficial, no direct side effect there. Okay, let's talk about the skin. Skin, right. So generally, steroids inhibit collagen synthesis. So the steroid inhibits collagen synthesis. It can also increase the breakdown of collagen because we said steroids increase proteolysis, right? So it can increase the breakdown of collagen in the skin. That's why patients that have Cushinism, patients taking high dose steroid, they can have what? They can have skin thinning. The skin looks thin than normal, thinner than normal, which means also what? Prone to injury. So you might see like purpuric lesions on the skin because if the skin is thin, the vessels in the skin can rupture easily. You might see, right, purpuric lesion, yeah, on the skin. Also, we're going to see striae, marks on usually the lower abdomen, right? Yeah, because of stretching of the skin, we're going to see all this striae on the skin, usually on the abdomen. And also, for wound healing. Yeah, so these people, they have an injury or they have a wound or they undergo surgery, we have an incision, it won't heal properly. Right, steroid.
Yes, sir.
Then, proteolysis or muscle breakdown in the protein breakdown rather, or proteolysis in the muscles. That's why you're going to see, like you mentioned, thinning of the word extremity, right? In those people. So they have central adiposity, but the extremity is thinning like a broom because the muscles undergo atrophy. They look very, very small because you're breaking down. Cortisol can trigger or steroid can trigger the breakdown of proteins in those muscles, right?
Okay.
And I'm going to tell you why it does that. So break down those proteins in there. And if the muscles are thin, what happens? Myopathy, weakness. So, and the proximal muscles are usually more affected than the distal muscles. So these people have weakness with raising their shoulder, weakness with picking something up from the overhead, right? Yeah, from the cabinet in the kitchen or something like that. Yeah, the problem with lifting their grandchild up, yeah, because they cannot even raise their hand above their shoulder. You would think, okay, proximal muscle weakness, you can see that with steroids. Yeah. Then, why is there proteolysis? So let me link that before we move on. Proteolysis, right? The reason cortisol, so all those proteins, we're breaking down proteins in muscles, breaking down proteins in skin, breaking down collagen. All those amino acids, what do we use them for? All those amino acids will go to what? To the liver, where cortisol will stimulate what? It's going to stimulate gluconeogenic enzymes. And those enzymes will use what? All those amino acids as a raw material, right? To make what? To make glucose. And that is why there's hyperglycemia in Cushinism.
Okay.
New onset diabetes or hyperglycemia or glucose intolerance. Yeah.
Yes.
Okay. And we know if glucose is high, well, there's going to be glucosuria. Glucosuria itself can increase it for UTIs, right? UTIs, vaginitis, right? Yeah, because of too much glucose in the urine. So, like secondary effect there, we see there. Then we already mentioned central depositing. Yeah. Right. So moon phases also because of fat redistribution of adipose tissue, right? Moon phases, they have the buffalo on central depositing. Yeah, extremely. Yeah. So those are going to be the major, yeah, features of Cushionism. And then electrolytes. So we'll go to the labs. Physical exam, okay, done. Go to the labs. We already mentioned the WBC. We're going to see neutrophilia. We're going to see lymphopenia. We're going to see eosinopenia. Eosinophils will be low. Then we are going to see electrolyte wise, we might see hypokalemia because, like you said, cortisol or steroids, they have like some mineralocorticoid activity. We might see potassium wasting. We might see normal or high sodium. Yeah, in those patients, we might see metabolic alkalosis because of loss of hydrogen ion. Yeah, on the labs, you might see those. Yeah, also on the lab. So that's steroids. That's steroids. Now, oh yeah, let's link to endocrine. So a patient, okay, we know Cushionism, the body is making, fine. Now a patient is taking steroid from the outside. Why is that bad? Somebody is taking high dose steroid. What would that do to the adrenal axis? If a patient is taking exogenous steroid or exogenous cortisol, what would that do to the adrenal axis in the body?
That will shut down central production. Yes.
It's going to shut down
Central production. Well,
right. So it's going to suppress what? Suppress the CRH, corticotropin releasing hormone that is made in the hypothalamus. Suppress what? ACTH made in the pituitary gland. And ACTH is low. What happens to the adrenal gland?
then it goes to atrophy because it's not
atrophy, and there will be no endogenous cortisol production in that patient. Right. Patient is not making cortisol. Right. So no endogenous cortisol production. Patient is not making cortisol. So the only source of cortisol in that patient is what? Is the drug they are taking, medication they are taking. That's the only source.
Yes.
So imagine if we now what? Abruptly stop. Patient run out of their medication and they stop the medication. What happens? The body is going to be left stranded because the body is not making cortisol. There's no more intake. Done. Patient will undergo what? Acute adrenal crisis. Those are people that are going to shock, hypovolemic shock, and they can die. They can die suddenly because there's no cortisol to maintain pressure, to maintain glucose. Yeah, nothing. Okay. And that is why in clinical setting, if someone is on long-term steroid, we do not just stop the steroid. What do? We taper the dose. We decrease the dose slowly, right, over a couple of days, weeks, and stop until we stop it finally. Because by decreasing the dose slowly, what are you doing? CRH will start recovering. ACTH will start recovering. The adrenal gland will start recovering. And by the time I stop the drug finally, what happens? The adrenal gland has recovered. The body starts making its own cortisol. So yeah, patient will not be left stranded in that case.
Yes, sir.
So steroids, I yield. And they're interested in those mechanisms as well as knowing, not just knowing the side effect, and we have to know how it works and also how it causes, right? Those side effects or why. Yeah. So those are what they're interested in. And we know steroid hormone, well, just like every steroid hormone, steroids, cortisol, etc., they have what? Intranuclear, right? Receptors. They usually work by regulating, right? Gene expression. Yeah. So, all right. So that is that. Back to the respiratory system. Another drug that we can use respiratory pharmacology for, like asthma, would be what, like omalizumab, right? Omalizumab, which is a mast cell, right? No, it's IgG, right? Yeah, antibody. Yeah, omalizumab. IgG antibody. So binds to IgG, prevents IG from targeting mast cells, prevent degranulation, right? That will minimize inflammation in the airways. And then we have a mast cell stabilizer. I can't remember the name. Sometimes that works as a, is it?
Cromolyn, right?
Cromolyn, right? Cromolyn is a mast cell stabilizer, which basically means that it prevents mast cell from degranulating, right? And which prevents the release of pro-inflammatory cytokines and prevents inflammatory infiltrates also. So those two are also like anti-inflammatory, right? Drug modulators, basically, yeah, based on the way they work. Okay, so those are also other drugs I want to know for sure, right? For asthma. Respiratory system, they can also test what drugs for just an allergy, right? Yeah, somebody comes in with rhinitis or they have allergic rhinitis, conjunctivitis, to see what can we use. Those are where our antihistamines come in, right? The H1 receptor blockers. Those we give, right, to modulate allergic reactions. For the H1 blockers, there are two generations. There's the first generation, right, and second generation H1 antihistamines. Yes. What's the difference between them? First generations, they can cross the blood-brain barrier. So they have what? CNS side effects. More CNS side effects compared to what the second generation antihistamines. Yes. So diphenhydramine will be a classic, right? First generation antihistamine. Just like loratadine and co will be an example of a second generation antihistamines. And yeah, and that's important because if I block another thing, and they also like testing it. So antihistamines, of course, we want to block antihistamine, the H1 receptor in the mucosal respiratory system TC to modulate, as well as on the immune cells to modulate allergic reaction. However, if you block histamine receptor in the brain and brainstem, it causes sedation. Right. These people will be sleepy. They can sleep into a coma. Which means somebody taking an antihistamine, the first gen, avoid other sedatory drugs in those patients. Right? Somebody taking an antihistamine, especially the first gen, avoid other sedatory drugs in those patients. Yeah. So that is important. Then another sedatory like maybe zolpidem and benzos, barbiturates, right? Yeah, want to avoid those in those patients because of addictive sedatory effects. Then they can also ask you, right? They can make you choose. So let's say somebody has an allergic reaction, has rhinitis or something, and the patient's job, what the patient do, requires that they are alert, awake, oriented. Then we cannot use the first generation antihistamine, right? We have to use the second gen. The second gen, they cross the blood-brain barrier, they have less, right, sedatory effect. Imagine a pilot that has allergic rhinitis. You can't give them a first gen antihistamine. Yeah. So, or someone that needs to be awake for a night shift, I can't give a first gen antihistamine. So I'm going to use a second generation, right, antihistamine in those scenarios. Yes. Right. So that is important. For first gen antihistamines also, they can cause other side effects that has to do with interaction with non-histamine receptors. Because of structural similarities between histamine, a slightly structural similarity between drugs like histamine and molecules like histamine and acetylcholine and norepinephrine, epinephrine. The drugs that we use, like first generation antihistamines that we specifically designed to block histamine receptors, they can sometimes cross-react and block what? Muscarinic receptor as well. They can block alpha-adrenergic receptors. And that is why you may see what? Anti-muscarinic effect in somebody taking what? Antihistamine. They can also have dry mouth, dry eyes, constipation, urinary retention, hot, dry skin, right? Anti-histaminergic, anti-muscarinic, right? Side effects. They can also have orthostatic hypotension by blocking what? Alpha receptors, right? As a side effect.
Okay. Yes, sir.
With that, they can ask you. All right. So that those yeah, the important ones. I know we can also use drugs like ephedrine, phenylephrine to treat like rhinitis. Those ones are vasoconstrictors, right? They constrict the mucosal vessels and decrease the blood flow to the mucosa. That will decrease the bulkiness and secretions. Yeah, so those can also be used. We also have drugs that are mucolytic drugs, drugs that can break down mucus in the airways, like N-acetylcysteine, right? Yeah, that kind is a mucolytic drug. It can break down mucus. So patient with like cystic fibrosis, chronic bronchitis, that may benefit from that to break down any mucus that's blocking up, right? The airways.
Yes, sir.
Yeah. And also cough suppressants, dextromethorphan. Yeah, it's a cough suppressant. I think there are other, I think guanifacin or something like that. One thing they love to ask about cough suppressant is we want to use a cough suppressant that does not have a CNS side effect or CNS suppression, which will,
Yes.
because of the risk of maybe aspiration or something like that. Dextromethorphan it can be converted to, no, dextromethorphan doesn't have, I think, the CNS effect, but drugs like codeine, yeah, codeine, right, is a cough suppressant that has, because an opioid that can cause CNS suppression and increase the risk for maybe addictive effect as well as aspiration. So yeah, but dextromethorphan is a cough suppressant that doesn't have the opioid effect. So we can use that in patients that we are afraid of, or they have high risk for aspiration or have high risk for addiction, right? You can use drugs like dextromethorphan, right? Like instead of codeine. Yeah. So that also they can test. All right. So I mean, those are respiratory farm is not that big a deal, but we have to know the details. We have to know the receptors. We have to know the signaling pathway for those receptors. Yeah. And they can, instead of just giving you, okay, I give somebody a beta 2 agonist like albuterol and co, instead of asking me how the receptor, what is the like what, they're going to ask you which of the following will be high in the cells. Cyclic AMP will be high. Adenine cyclic activity will be high, right? So like protein kinase A will be high, right? Because now they're going to be testing about the second messenger or the signaling pathway. They're giving me a drug that is an anti-muscarinic drug, ipratropium, tiotropium. They're going to be asking what will be low in this patient's cells. It's going to be calcium will be low. Activity of phospholipase C will be low, right? Because those are under the GQ, right? Pathway, things like that. Yeah. So we gotta know, right? Those cellular, right? And molecular components of those receptors, because that's how they're going to test them. Make sense?
Okay. Yes, sir.
Okay, respiratory micro. Starting with the nose, of course, we can have things like